And Teshikuradam. So thank you very much, President and Madam Co-Chair, and thank you very much for inviting me to speak, and it's a great pleasure to be here. Myself and many of the people from the UK are very involved with the British Association for Psychopharmacology, which is a sister organisation to Year One, so it's a particular pleasure to be here. And today I'm going to talk about treatment-resistant depression, concepts, causes and cures. And this is a topic which is of great topical interest because after a long period in psychiatry where we haven't seen new treatments, really new treatments, we're beginning to see really new treatments come through. Including some which are already licensed. So this is of great optimism. But I'm not really going to major on the pharmacology. I'm going to mention that briefly at the end. But I'm going to talk about treatment-resistant depression, what it is and what it means. So these are my disclosures. I'm employed by King's College London. Our dear Queen died recently, and we had some visitors from Germany at the time, and they asked me, now that the Queen has passed away and we have a king, does that mean that King's College is the most important university in Britain? And the answer is, of course, it does mean that. We are the most important university. And I also work in the Maudsley Hospital, and I'm involved with the National Affective Disorders Service. So here's the outline for my talk. I'm going to review the concept of treatment-resistant depression, what that means. I'm going to outline the causes and clinical aspects of treatment-resistant depression. I'm going to go through some of the detail about therapeutic strategies for treatment-resistant depression. And lastly, I'm going to report data that we've just published on how well the depression treatment pathway is implemented. And that's data from across Europe. So to start off with, what is the global context of depression? Well, if we look at the WHO studies about the burden of disease, and remember, the burden of disease studies were essentially started to quantify the cost of all diseases. And surprisingly to many people, mental health disorders ranked as some of the most costly or the most burdensome. And this is on a metric called the Disability Adjusted Life Year. Now this data really comes from the 90s and further forward, but the message is quite clear. In terms of all disorders, 5 of the top 10 are mental health disorders. And these will be familiar to many of you. Unipolar depression, bipolar affective disorder, alcohol use, self-inflicted injuries, and schizophrenia. So this is true across all of the world. In some other localities, infectious or communicable diseases, things like TB and so on, are relatively higher. That's particularly true in sub-Saharan Africa. But for countries like Turkey, the UK, United States, and so on, the 5 mental health disorders will be some of the most important health conditions. So what about the epidemiology of depression? Well, again, this is the WHO data, and you can see by world region, and you can see African, Eastern Mediterranean, Europe, Americas, Southeast Asia, Western Pacific. The total number of people living with depression in the world is 322 million. And that's about 12% in the European Union. So this is an enormous public health problem. Okay, moving on to treatment-resistant depression, the first formulation of this was in the mid-1990s by John Rush and Michael Thays, who published a scale for treatment-resistant depression, which I'll come on to talk about in a few moments. On the plane here, I was reading the obituary of Professor Beck, who invented CBT, who's accredited with really being the founding father of cognitive behavior therapy. And what's very interesting is that the first paper in the 1970s that Tim Beck published on CBT was co-authored by John Rush. In actual fact, John Rush was the first author. So this, to my mind, illustrates a very important point that when we're thinking about treatment of depression, we shouldn't just be thinking in silos about pharmacology or psychotherapy or neurostimulation. We should be thinking in the round. And John Rush's career, which spans both cognitive behavior therapy and many important contributions to treatment-resistant depression, exemplifies that. So, from the STAR-D data, and I'll come on to talk about this in a moment, the definition is a patient is considered therapy-resistant when consecutive treatment with 2 antidepressants of different classes used for a sufficient length of time and at an adequate dose fail to induce an acceptable effect. Now, we've probably moved on to the point where we no longer require the antidepressants to be of different classes, because studies that were done by Michael Thays, who with John Rush authored this definition, show that if you switch from a SSRI to an SSRI, you still get about the same response rate as switching from, say, an SSRI to a SNRI. So we don't really require it to be 2 different classes. But the bad news is that fewer than 15% of patients who fail 2 antidepressants are likely to meet remission in the next treatment step, next 2 treatment steps. And for those who do reach remission, many do not sustain it. So we think about treatment-resistant depression as being a simple failure to remission, but many patients who do reach remission do not sustain it. And this, of course, is not news to any clinician, but it's often forgotten about when discussing the research evidence base for treatment-resistant depression. Now here's the STAR-D results. So, many of you will know what STAR-D was. It was a large sequenced treatment algorithm. Everyone was treated initially with citalopram for a number of weeks, and then there were a number of secondary steps. Other drugs were added or they were switched. CBT was an option, ECT was an option. But the overall cumulative remission rate after 4 treatment steps was only 2/3. So even after 4 treatment steps, only 2/3 of people reached remission. And with each treatment level, the remission rate reduced, treatment intolerance, which is a very important factor, rose, and relapse rates rose as well. And you can see this is shown in the schematic here, where you can see intolerance, relapse, remission, and you can step 1, step 2, step 3, step 4. Now, a very important weakness of STAR-D is shown, if you can see it here. At the first stage, there were about 3,600 participants. By the second stage, this had dropped to just over 1,400, and then 390, and then at the end, there were actually only 123 patients in it. So bear in mind this fundamental weakness of STAR-D. I'm very friendly with John Rush, and John makes it quite clear that this is a weakness of the study. In some ways, it's also informative about the nature of treatment-resistant depression, because even if you're in a place like the United States where you're getting treatment for free in a study, which is highly valued, you might drop out of the study, and the dropouts are really very high. And of course, people drop out of treatment all the time in clinical practice. Excuse me. Okay, so based on STAR-D, there are two pathways to TRD: failure to respond and failure to retain or sustain the response. But current definitions of TRD focus exclusively on acute trial failures without considering those that do respond and then slip back. Because of this, our current TRD definitions fail to capture a very large proportion of depressions for which numerous treatments fail. A very important point to remember. What about the burden of TRD? Well, I've said that depression is one of the most disabling disorders and causes a significant burden both to the individual and to society. Now, in many European and North American countries, companies, employers, and indeed even the government are worried about depression in the workplace because this reduces productivity. Not only because of absenteeism due to sick leave, but also because of so-called presenteeism, where the person is going to work but performing suboptimally because of depressive symptoms or cognitive impairment. So, although WHO data suggests that depression causes 6% of the burden of all diseases in Europe in terms of disability-adjusted life years, this is disproportionately greater in treatment-resistant depression. So if we look at the total cost of depression in Europe, and this is an estimate from a few years ago, it's 118 billion euros, and it's separated out into direct costs and indirect costs. I have had the pleasure of working with health economists over the years, particularly our health economists at King's, and it's very interesting that they quantify the costs of disorders, and this is very important in terms of framing government policy. I'll come on to that at the end when I talk about our European study. But you can see the direct costs of depression, outpatient care, drug costs. Drug costs are a very small proportion. Hospitalization was about 42 billion in this study. Indirect costs due to morbidity, mortality, reduced workplace productivity, 76 billion euros. And this is shown schematically here at the bottom. In terms of TRD specifically, this study from the United States looked at the total healthcare costs of treatment-resistant depression. And you can see the comparison group here, outpatients and hospitalized, hospitalized being the most treatment-resistant. The total costs were 4 times greater in the outpatient treatment group than the comparison group, and 6.5 times greater in the hospitalized group. And total depression-related costs in the US in the hospitalized treatment-resistant cohort, this one here, were 7.5 times greater than those in the outpatient group and 19 times greater than those in the comparison group. You might say, I'm a psychologist, psychiatrist, or a clinical nurse specialist. Why should I be interested in health economics? Well, the health economics drive the healthcare budgets. So it's very important that we are aware of this. And the healthcare budgets are driven on evidence. And the evidence is there should be a good, large spend on things like treatment-resistant depression. Okay, further data, if it were needed, just to show that this is again showing healthcare utilization increases with greater degrees of treatment resistance. Now, healthcare utilization in treatment-resistant depression is not just utilization of mental health services. People with treatment-resistant depression have an excess, a disproportionately large utilization of other healthcare resources, visiting their family doctor, attending general health clinics for cardiovascular disease, and so on and so forth. And you can see this is shown here, that healthcare utilization increases with the greater degree of treatment resistance. So if you get up to the end of star D, you can see the total is much more than at the beginning. And this, of course, is once again broken down into inpatient, outpatient, pharmaceutical costs, and others. Now, one of the big costs to society is lack of productivity and engagement in the workforce, as I've said. And this is a big issue with, for example, in the UK. In the UK, we've got historically low levels of unemployment. So there's very low levels of unemployment, but we have a very large number of people who are disabled due to depression. And these people could be engaged in the workforce. So these are really a hidden unemployment rate. And that's true across Europe. You can see here, going from Germany through to Norway. I'm just very quickly trying to see if Turkey's on there, but I don't think it is. But you can see this is the workforce participation rates for the general population without depression in all of these countries. And this is the rate it is if you've got depression. So markedly, clearly lower. So people reporting depression have a lower employment rate, and only about half, 50% of the population aged 25 to 64 with chronic depression were in employment, compared to about 3/4 amongst those who did not. And of course, this causes lost income to the individual, but also increased costs and reduced income for the economy as a whole. Okay, what about comorbidities? Well, comorbidities are very common among patients with depression, and particularly common amongst patients with treatment-resistant depression. In terms of psychiatric comorbidities, you can see they're all increased, but we've found in our studies in London that the physical health comorbidities, things like cardiovascular disease, diabetes, and so on and so forth, are also markedly increased in the treatment-resistant depression population. Now, in this session that we had this morning, there was a question about adverse life events in general. And of course, adverse life events, especially adverse life events in early childhood, have a significant negative effect on treatment response and recovery in depression. Adverse life events in childhood are associated with an increased rate of depression. This was very well shown in a study from Newcastle, where I used to work, which looked at 1,000 serial births in the late 1940s, and then followed these individuals up when they were 35. And during the first year of life, adversity was measured by health visitors on a simple 6-point scale. Now, for those children who grew to be adults, at the bottom half of the scale, the rate of depression reported at 35 was about 5% experience of depression. For those who had the top half of the scale, it was 35%. So clearly, early adverse life events can be associated with increased rates of depression. And also, they have a significant effect on treatment response. So patients, and this is a very nice paper by Leanne Williams from the United States, patients who experienced trauma in childhood were significantly less likely to respond to treatment and achieve remission. So if you look at responders, far higher with no abuse than abuse, and remitters, similarly, far higher with no abuse compared to abuse. Now, early adverse life effects, I think, are a general factor for mental health disorders, but they're certainly a very key for mood disorders and should be part of our thinking about the origin and indeed possibly the treatment implications for treatment-resistant depression. And I'll talk about that when I talk about treatment. Okay, what about mortality? If you work with epidemiologists, they talk about hard outcomes. And of course, many of the things that we deal with in psychiatry, change on a rating scale or whatever, are relatively soft outcomes. But perhaps the hardest outcome is death, and it's one that's difficult to fake. I don't think there's a placebo effect with death that I'm aware of. So it's a good measure to actually assess the impact of a disorder. So the highlights from this Swedish study is that mortality is higher in patients with treatment-resistant depression than in other patients with depression. And of course, patients with depression have an increased rate of death compared to the general population. The increased mortality in treatment-resistant depression is mainly attributable to so-called external causes of death, and I'll talk about that as I go through the methodology. And young and physically healthy patients have the highest relative mortality increase. So sometimes in psychiatry, some other specialties feel that our disorders shouldn't perhaps be taken seriously because it's just people reporting symptoms, but there's a real impact here on death rates. So just to drill down into the data, this was using the Swedish national registers with about 120,000 individuals aged between 18 and 69. Patients with 2 or more additional treatment trials during the same depressive episode were classified as having treatment-resistant depression, so standard definition. Data on the covariates of sex, age, history of depression, self-harm, substance use, and other psychiatric and somatic comorbidities were ascertained. And the relative risks comparing treatment-resistant depression patients with other depressed patients were calculated as hazard ratios for all-cause mortality, for external and non-external causes of death, with excess mortality rates with 95% confidence intervals. Okay, so in total, about 15,000 patients were classified with TRD. The adjusted hazard ratio for all-cause mortality compared to depression, which remember is already increased, was 1.35. Mortality from external causes, and remember external causes include suicide and accidents, was markedly higher in treatment-resistant depression than in other depressed patients, whilst mortality from non-external causes was similar. So this is usually due to things like suicides and accidents. And the adjusted mortality rate was highest amongst the younger patients, 18 to 29, and patients without somatic comorbidity. Now, of course, with any large database, such as the Swedish or Danish or Finnish databases, there are limitations due to what's available in the database. But nevertheless, I think from this we can conclude that patients with treatment-resistant depression may have an increased all-cause mortality compared to other depressed patients, mainly due to these external causes of death. And tragically, the relative mortality is highest amongst young and physically healthy patients. So what about suicidality in treatment-resistant depression? Well, of course, suicide is the leading or second leading cause of death in young people in most countries. It's either road traffic accidents or suicide. And in actual fact, if there are laws mandating wearing seatbelts, then road traffic accident deaths are usually lower than suicide. So it's a big deal. 30% of patients with treatment-resistant depression attempt suicide at least once during their lifetime. However, it is unclear what the attempted and completed suicide incidences are after treatment. There's been a worry that some of our treatments actually increase suicidality and whether they actually decrease suicidality. So this paper did a systematic review of PubMed for studies of depressed patients who'd failed 2 antidepressants therapies, were followed up for 3 months after initiating a treatment. They estimated attempted and completed suicide incidences, and meta-regression was used to analyze the statistics. So here you can see the different studies looking at different treatment modalities, ranging from neurosurgery for mental disorder, cognitive behavior therapy, deep brain stimulation, ECT, ketamine, vagal nerve stimulation, and treatment as usual. And you can see that generally there isn't a signal of treatments causing an increase in suicidality. Now, on the plane on the way here, I read the most recent edition of the British Journal of Psychiatry, as I'm sure you all have as well, particularly my colleagues from the UK. There's a very nice longitudinal follow-up study, not a randomized trial, but a longitudinal follow-up study of suicide and suicidality after ECT. And if you follow people who've had ECT up, there's a 25% reduction in suicide. So I think ECT in particular, and we've also heard about ketamine. We know that ketamine reduces reported rates of suicidality. But remember, it's very difficult to get a signal about what is still a comparatively rare event, such as suicide, in trials. So, of the 30 studies investigating suicidality, 32 samples, you see there was deep brain stimulation, vagal nerve stimulation, ECT, treatment as usual, neurosurgery for mental disorders, CBT, ketamine, and epidural cortical stimulation. The overall incidence of completed suicides was 0.47 per 100 years, and of attempted suicides, 4.66. And there was no difference in incidence from any of the more interventional treatments, deep brain stimulation, VNS, or ECT. But as I've said, more recent data, very recent, suggests a 25% reduction with ECT. So, completed and attempted suicide rates are high, but these did not differ between 3 of the more complex interventions. Given the high suicide risk, clinical trials should consider suicide as an explicit outcome measure. I would disagree with that from the paper because I think suicide is always going to be a rare event. I think what we need are observational cohort studies, such as the one I just mentioned, which was reported in the British Journal of Psychiatry. Okay, I now want to drill down for a few minutes on the models of TRD. And this is very important because you'll be told about treatment-resistant depression, but I think it's important that you understand the subtleties of what that means. So this is the original Thays and Rush paper from 1997, which is really quite a long time ago now. If you look back on when doctors started talking about treatment resistance. They began talking about this in the middle of the last century with regard to antimicrobial treatments. So you'd have, for example, tuberculosis that was resistant to various drugs. So Thays and Rush did this first for psychiatry, and really we were quite late to the scene. Stage 1 is failure of one adequate trial. Stage 2 is what we now understand as treatment-resistant depression. But as I've said, we do not adhere to the need for it to be distinctly different. Then they had stage 3, which was stage 2 with failure response for tricyclic. Stage 4, adding in an MAOI, of course, after taking the other drugs that might interact with the MAOI away. And stage 5 was bilateral ECT. Should be said, and we published this in 2019 in the British Medical Journal, that of all treatments for an acute depressive episode, bilateral ECT is the most effective. It has more side effects, of course, than unilateral, but also more efficacy. So what about Thays and Rush's treatment-resistant staging model? Well, it was developed to be a guideline and to help psychiatrists. It's easy to use and implicitly gives you a strategy for clinicians to treat treatment-resistant depression. You go from stage 1 to stage 2 to stage 3 and so on. There is an assumption that certain antidepressants are more effective than others, regardless of the type of depressive episode. So this is very important. I think there is evidence that some antidepressants are more effective in general. So for example, Andrea Cipriani's Lancet meta-analysis did show that drugs like amitriptyline were the most effective. But there are important subtypes of depression. So we have a whole work stream in our group on atypical depression, where you have increased weight, increased sleep, increased appetite, and so on. And we think there's intriguing but not definitive evidence that MAOIs are better than other antidepressants for this type of depression. They didn't really think about switching from one SSRI to another, although Michael Thays did that afterwards. And augmentation and combination strategies were not really considered. And lack of response to one antidepressant was considered to be stage 1 resistance. Now there's a plethora of other staging models, but for simplicity, I'm going to present our own one, the Maudsley staging model, which was done by Abi Fukuda, who was a visiting psychiatrist, and Professor Tony Clear, who's my colleague. And they've done the initial work and they've done much follow-up work on this staging model. And this is really something for the expert clinic or the research setting. The principal added value of this model consists in the possibility to emphasize in each case the most important factors of the presenting episode which contribute to treatment resistance. And these include the duration of the episode, the severity of the episode, mild, moderate, severe, and the number of failed treatments. However, the model is not entirely comprehensive. It does not include psychosocial stressors, functional impairment, or comorbidities. But importantly, Tony and Abi validated the model through a prospective follow-up, showing a significant association with and an ability to predict persistence of depressive disorder. And they've also shown this in another cohort in the Netherlands with colleagues there, Brenda Penix and others. So Maudsley's staging model is an important one to consider and to look at. I now just want to go back to the more simple model about treatment-resistant depression and say that there may be an empirical validation of the two failed treatments. And this is a nice paper from JAMA Psychiatry, done by Charles Conway, Mark George, and Harold Sackheim. I'm currently working with Harold on a number of papers, and indeed Charles Conway as well. And Harold is very clever and very creative in looking at data. And he did this with the STAR-D data. And you can see here, this is another representation. First level of STAR-D, which is citalopram, and then the possibility of switch, combination, so on and so forth, and then on to further more interventional treatments. And this is also shown on this side, and you can see pretty good response to the first stage, dropping a little bit in the second, but then it drops off markedly. And in the paper, Chuck Conway and Harold talk about an inflection point where the rate of treatment response really drops to about 13, 14, 15%. And I think that's true. No matter what you do after this stage, at least with the treatments that they used, and it may be different with new treatments, you're going to have limited gains, although you will have some gains. So they proposed that this essentially confirmed TRD, but they also said that we should perhaps think about TRD in two different ways. Stage 1, treatment resistance, failure of 2 adequate dose duration antidepressants or psychotherapy from different classes, either in combination in the current episode, so that's STAR-D level 3. And this degree of resistance may warrant less invasive novel mechanisms such as TMS, ketamine, and S-ketamine, of course, which is licensed at this level, and then other things such as buprenorphine or ECT in some cases. And then stage 2 TRD, failure of 3 or more adequate antidepressants or psychotherapy trials. This is STAR-D level 4. And this may warrant more invasive or higher risk treatments, such as surgical interventions, including vagus nerve, deep brain stimulation, or thinking about ECT. So I think this is a very helpful way, and to some degree is based on data. It's based on looking at the response rates in STAR-D. So what to conclude about TRD staging? Well, the proposed models give guidance in defining TRD, but have important limitations. People have questioned the validity. I think the paper by Conway, George, and Sackheim that I've just discussed actually does give some underpinning to the validity of the definition. But the clinical use remains limited. And of course, clinical trials in treatment-resistant depression have been few and far between. There's more going on now, and of course I think that's because of the influence of S-ketamine, which was really the first drug that was licensed for treatment-resistant depression. It's possible that further research might result in a revised TRD definition, although I'm not sure that will happen. But the standardized TRD definition should include the use of evidence-based novel treatments and thinking about more interventional treatments for people with higher rates of treatment resistance. So in terms of take-home messages for your clinical practice, I think you should be thinking globally about the patient, the depressive episode, the nature of the depressive disorder. I've mentioned atypical depression, treatment options and treatment adequacy. And you should also be thinking about how can I anticipate treatment failure, what to do next when treatment fails. Now, a very important and useful addition to the debate, or to our thinking, is difficult to treat depression. And again, this was something that came from John Rush. And this is complementary to treatment-resistant depression. So this doesn't take away from treatment-resistant depression. I think treatment-resistant depression is a concept that's there, but difficult to treat depression is complementary and in many ways describes what we do clinically. So there's a compare and contrast here. So Difficult to treat depression is more of a collaborative concept with the patient, the family, and the doctor. Treatment resistance is more about the episode. Difficult to treat is more about chronic illness. The approach for treatment resistance is very focused on biological, but in the difficult to treat depression model, there's biopsychosocial capability, recovery, optimizing symptom control, and minimizing impact of symptoms. And importantly, TRD is categorical. You either satisfy the criteria or you don't. And difficult to treat depression is dimensional and allows for waxing and waning of the symptoms, which of course we all know happens. So what to do when difficult to treat depression is suspected? Well, one should assess and remediate any and all obstacles that stand in the way of sustained asymptomatic recovery. But these efforts may not produce full remission in all patients, and really we should be focused then on optimizing disease management, symptom control, better daily functioning and quality of life, rather than persisting in perhaps chasing just a full remission in terms of other steps. So what do we do with DTD? Well, this is very much what we do in our clinic. We confirm the primary psychiatric diagnosis, and this is something that can actually sometimes be very wrong, and it can take, there's a very important point here that it's worthwhile investing quite a period of time reviewing the psychiatric diagnosis, and also the adequacy of prior treatment recommendations with dose and duration, adherence to prior treatment recommendations. Now, we saw in the symposium I co-chaired this morning that adherence to treatments is very often poor. Then we should consider pharmacogenetics or therapeutic blood monitoring. We certainly do therapeutic blood level monitoring, and we're part of a large European study looking at pharmacogenetics and how it predicts response and tolerability of antidepressant treatments. Then you should assess any concurrent psychiatric conditions that require remediation. The same for general medical conditions and undiagnosed general medical conditions. And lastly, evaluate current environmental stressors that require remediation. And it should be thought of as a chronic disease management strategy. So a core feature of a disease management practice is to help patients accept the reality of their condition, focus less on symptoms, more on quality of life, social functioning, compliance with treatment. So I think that's very important. This means that we should really be engaged with our patients long term, if necessary, something which is very difficult in many healthcare systems. Okay, but let's return to TRD and talk about sustained asymptomatic state, which would be accompanied by return to the pre-morbid level of functioning with minimal interference in the patient's life from side effects or other burdensome aspects of the treatment. And just to reiterate that if you look at the evidence so far, 1/3 of patients will develop treatment resistance. Now, this is 1/3 of patients who are treated, and I will show you data that we've just published showing that many patients are not treated. So step one, step two, this could be pharmacotherapy or psychotherapy, it could be switch, add-on, combo of psychotherapy and add-on. You'll still have 1/3 of patients going into the TRD category. Now, an extremely important point, and I think this is one of the things that clinical psychiatrists and psychopharmacologists who treat depression are very aware of, is that the patient treatment preference impacts treatment response. So this is work from Papakostas and Koskas. These are not randomized to different groups, but it looks at the medication group, the psychotherapy group, and the combination group, and in terms of the preferred treatment. So for this group preferred medication and got medication, this group preferred psychotherapy and got psychotherapy, and this group preferred the combination and got the combination. And the remission rates were really powerfully influenced by patient preference. So you can see if you preferred medication, you did best with medication or the combination, really markedly less well with psychotherapy. If your preference was for psychotherapy, look at the remission rate with medication alone. Really shockingly low, but if much better with psychotherapy, actually less with the combination. Combination, you preferred the combination, and if you had no preference, you preferred best. You did best with the combination. So, the key point here, to my mind, is we should be discussing the patient preference with the individual. And if all other factors are equal, so there's no impact of cost and so on, we should be going with the patient preference. But we should also be trying to understand and engage in psychoeducation with the patient about the preference. Because very often the preference is fueled by misconceptions about the treatment. So, for example, some people who don't want medication are convinced it's addictive, which it's not, and so on and so forth. What about current treatment strategies for patients with treatment-resistant depression? Well, treatment strategies who haven't responded include optimization of the current therapy to exclude pseudo-resistance, augmentation with another agent, combination. Now, the difference between augmentation and combination is that combination is usually two antidepressants, although sometimes it's used for antidepressants and psychotherapy, whereas augmentation is usually adding a drug like lithium, quetiapine, or indeed S-ketamine to the regime. Dose escalation, which is certainly a strategy for some antidepressants, and switching to another antidepressant monotherapy. Although these strategies are common in clinical practice, evidence supporting their efficacy is limited. So, my colleague Tony Clear, myself and others have just done the biggest trial of lithium versus quetiapine in people who haven't responded to antidepressants. I don't have the data to show you because it's still being analyzed and cleaned, but it's interesting that this is really only the second and certainly the biggest study of this very commonly used strategy. So there's a paucity of evidence. Here's a treatment algorithm that was published a few years ago by Bartova et al. I'll show you our own Maudsley algorithm soon. But stage one is optimization and exclusion of pseudo-resistance, so looking at sufficient treatment duration, sufficient daily doses, therapeutic drug monitoring, metabolic abnormalities, evaluating treatment adherence, evaluation of adverse effects, and evaluation of comorbidity. Then augmentation strategies with lithium, quetiapine, as I've said, S-ketamine, combination treatment, dose escalation, and switching. There are clearly major unmet needs in the treatment of TRD. These include a lack of biomarkers. Great hope was put in inflammation and whether inflammatory biomarkers would guide our treatment choices, but as yet that hasn't borne fruit. A lack of recognition of risk factors and outcome predictors, and importantly, a lack of effective TRD treatments with a quick onset of action and sustained efficacy. We must bear in mind that major depressive disorder is incredibly heterogeneous or mixed. So we talk about major depressive disorder as if it's a single entity, but there are at least 681 symptom combinations for major depressive disorder based on DSM 2013 criteria. And my friend, Professor McAllister Williams from Newcastle, claims that he can do the maths, so there's well over 1,000. But regardless, there's hundreds of different symptom combinations, meaning that TRD is a heterogeneous state with probably multiple causal mechanisms. And that's true for major depressive disorder overall. So reaching an operational definition of TRD is challenging, and we'd much rather have a biological definition where you could do a blood test or a scan or something like that and decide which treatment pathway people should go down. That's what happens in oncology and rheumatology and other areas of medicine, but unfortunately we're not there yet in psychiatry. What about pharmacological options? Well, we talked about a lot of these earlier. My colleague, Dr. Allan, who's in the audience, was reviewing, and Professor Stone were reviewing ketamine and glutamate. Many of the new strategies are related to NMDA receptor antagonists or variations thereof. So, for example, the combination of bupropion and dextromorphan has been approved in the United States recently for treatment-resistant depression because they've shown that combination beats not only placebo, but also bupropion alone. And the dextromorphan is an NMDA receptor antagonist. So there's lots of NMDA receptor work. There's also work on muscarinic, vasopressin, and so on and so forth. And indeed, as Luke talked about in his lecture this morning, there's also possible opioid mechanisms, particularly the kappa receptor antagonist approach. But so far, we've only got one treatment which is licensed by regulatory authorities, and this is intranasal S-ketamine. I think this is a fascinating story. This began 20-odd years ago with Dennis Charney in the National Institutes of Mental Health, and they gave a ketamine infusion. Remember, ketamine is a mixture of R and S, and claimed there was a rapid reduction in depression and suicidality. Now, the journey from a small trial in a research setting to a licensed treatment is long and arduous, but S-ketamine made it. So Janssen selected the S enantiomer rather than the R because it's got a smaller volume and was therefore deliverable in the nasal spray. Remember, if you give ketamine orally, at least the formulations that we currently have available, the bioavailability is very low. So you need a non-GI delivery route, and the nasal route is accepted. So this was some of the studies that got the license. You can see placebo, S-ketamine, different doses, and you can see the superiority over the first 4 weeks. Now, one of the things that's often forgotten about the S-ketamine trials is the comparison arm, which had a placebo nasal spray, also involved going on a new antidepressant. And remember, the new antidepressant would probably have about a 15% remission rate. So this is important. The placebo group, so-called, in the S-ketamine studies wasn't placebo. It was a placebo nasal spray, but it had very much an active treatment component that would produce an effect. And some of the most important and helpful data, we took part in these trials, was the long-term treatment options. So this is the SUSTAIN 1, which is randomized withdrawal. And you can see if you withdraw the S-ketamine, you have an increased relapse rate. And if you continue the S-ketamine, you continue the benefits over about a year. So S-ketamine has really established the fact that these drugs which work probably through NMDA receptor antagonism, are drugs which have a helpful clinical benefit and can make it through the tortuous regulatory process in both North America and Europe. What about other options? Well, in the BAP guidelines, we talk about psychotherapy. I was very pleased to see that there's a very active CBT component to this meeting. And as I said earlier on, John Rush and Aaron Beck worked together on the first published study of CBT. But studies have shown that psychotherapy, principally CBT, although of course in a bespoke way we may want to include others, when combined with antidepressant treatment, gives benefits. And that's shown better on this slide here, where you can see usual care plus the intervention of adding CBT. And you can see a significant benefit here, and you can see the metrics for this here. So this, in many guidelines, is now recommended. Some guidelines it's recommended as the first option. One of the limitations of CBT is cost. So in the German guidelines, they point out that a year of SSRIs in Germany, where they're very good at containing costs, is about 80 euros, whereas a session of CBT would be 80 euros. So there's a play-off in terms of cost and benefit. What about non-pharmacological treatments for patients with treatment-resistant depression? Well, I've been through some of these, and I'll highlight them in a slightly different order from here. TMS, I think, is a helpful treatment. I think it is antidepressant. It may be useful in some cases of treatment resistance, but to my mind, there has not yet convincingly been good evidence of efficacy in treatment-resistant depression. Certainly not of the magnitude of ECT. Magnetic seizure therapy is still in development, so we won't really talk about that. Vagus nerve stimulation, which we do use in our center, is currently approved for TRD. It's difficult to get funded, but the long-term studies do show real benefits. So vagal nerve stimulation is something that comes on over the course of at least a year. It is widely used for treatment-resistant epilepsy. So in our hospital, our twin hospital, King's College Hospital, there's many operations every year with VNS for treatment-resistant epilepsy, but only comparatively few for treatment-resistant mood disorders. But nevertheless, I think it's something which can be of great benefit and is used in various European countries. And lastly, ECT. Now, ECT is one of our oldest treatments in psychiatry. It came in the mid-40s, 1940s, and in many countries across the world it's not available, which is very tragic, but it is certainly the most effective treatment for depressive episodes. And ECT is perhaps different from most treatments in there's a very small but vociferous and loud number of people who campaign against it, some of whom disbelieve in ECT on ideological grounds. But nevertheless, the evidence, this is from the UK ECT group, you can see if you add all the trials together, there's a clear benefit of ECT. And I think we have to try and be aware of this. We should use ECT judiciously. I would quite happily see the end of ECT. I'd be quite happy if ECT were never used again if we had a treatment that could replace it, that was as evidence-based and as beneficial. But as yet, we do not have that. Okay, so this is our treatment strategy. In the last 5 or 10 minutes, do I have 5 or 10 minutes left before questions? I think so, yeah. This is our Maudsley treatment pathway for people with major depression. First thing is to screen and diagnose depression. And then we should be very active in monitoring the response to depression. So we should be reviewing people at 4 weeks, between 2 and 4 weeks after initiating a treatment. And if they haven't shown at least a 20% response, then you need to do something. You need to dose escalate, switch, or whatever. And then you try that again. And then for people who have an inadequate response, it's not a linear pathway, but rather a carousel of different options to be decided by patient preference, the physician, and so on. And the options are switching, combining with psychotherapy or pharmacotherapy, or augmenting with drugs like atypical antipsychotics, lithium, S-ketamine, and so on. And then if the inadequate response continues, there's treatment options like VNS, TMS, and ECT. Now, of course, ECT might be given first if someone's got severe psychotic depression or catatonia, TMS should probably be earlier in the treatment strategy, but VNS is never going to be an acute treatment. It's for very severe, chronic, recurrent patients. And then you should maintain treatment for 6 to 9 months or for at least 2 years if the patient's at risk of recurrence. And Glyn Lewis, in a very nice trial published in the New England Journal of Medicine, has recently shown that people with recurrent depression who were maintained on antidepressants for 2 years, if they're then withdrawn, about 45% relapse. So some patients will not need more than 2 years, but some will. Okay, last 5 minutes, I just want to talk about our European Brain Council treatment study. These are my charming colleagues who helped me, particularly Rebecca Strawbridge. This is Paul McCrone, who's our health economist, and various colleagues from across Europe and so on. And I led this particular project in depression. This attempted to look at the gaps in care, how well this is implemented across Europe in terms of detection, treatment, follow-up, and so on. We talk about treatment-resistant depression, but there may be parts of the depression pathway that we could implement that we are not doing so at the moment. Now, this article was published a few months ago in European Psychiatry. Here's the QR code. You can get it from this. And I'm going to briefly show you the results. Just to say that we looked at different European countries, UK, Sweden, Germany, Italy, Portugal, and Hungary. And here's the headline results in terms of detection, treatment, follow-up, and access to care. And this is really quite shocking. So only 52% of depression was detected. Now, the good news is this is better than some previous studies. My colleague Graham Thornycroft published a study about 5 years ago suggesting only 25% of depression was treated. So this is a bit better, but only 52% is detected. And of that 52%, only 62% is treated. So that means only about 30% of depression is treated at all. And only 33% have follow-up, which is similar to what the guidelines would recommend, no more than 4 weeks, ideally somewhere between 2 and 4 weeks after starting a new treatment. 33% had some follow-up, and 33% had no follow-up, which is astonishing. Across Europe, there was only about a 19% access to psychiatric care. 80% of people were not seen by a psychiatrist, which is shocking, and there was a particular difficulty with access to psychological treatments. So in the paper, we make some recommendations. We say that we should improve treatment provision. I won't go through this in great detail, but just to say it's all listed here. Improve treatment provision. We particularly think that digital approaches, such as were covered in my session I co-chaired this morning, digital approaches may help adherence from detection to follow-up to symptom monitoring of the depression treatment pathway. So digital may help with continuity of care as well. This is something that is really woeful. We should be looking at optimizing tools such as this. We should have automatic scheduling an appointment and so on and so forth. And we should improve access to specialist care, both secondary and what we call tertiary, which is psychiatrists with a special interest in treatment-resistant mood disorders. And of course, there are some limitations of this data which we talk about in the paper, but I think overall it's a sobering message about the provision of care for depression across Europe. And unless we treat depression better using the tools that we have available, we'll be dealing with more treatment resistance and poor outcomes. And that's just to say thank you very much to the funders, the European Brain Council, my colleagues, and so on and so forth, and particularly Dr. Strawbridge, who pulled this together. So to summarize my talk, treatment-resistant depression is a very important topic for all psychiatrists and arguably all doctors. It's development is impacted substantially by factors such as comorbidity and early life experiences. For the patients, the most important remission factor is the presence of positive mental health. And this speaks to anhedonia being such an important and damaging state. And treatment effectiveness also relies very much on patient preference. Current unmet needs include the identification of biomarkers, risk factors, outcome predictors, as well as fast-acting efficacious treatments. But we do have treatment strategies for TRD, which we can use to improve detection, augmentation, combination, switching. I would urge you to look at the data and the papers on difficult-to-treat depression, because I think this is an interesting and potentially helpful way of considering these. Implementation of our depression treatment pathway is poor, and I think that's probably true in every country. My great hope is that digital tools, if properly harnessed, may actually improve detection, treatment, review, symptom monitoring, and so on. And lastly, the exciting bit is novel therapies are in various stages of development. We already have esketamine, which is a licensed treatment. We have bupropion and dextromorphan, and we have other treatments which all, I think, focus on this current relationship between glutamate, GABA, and the NMDA receptor. It's possible even that psychedelics also work through this same mechanism as potential treatments that will become available in the next decade or so. And I think that's a very exciting time for psychiatry. These are some references, and thank you for your attention.